We welcome you on the behalf of the Department of Endocrinology, Metabolism and Diabetes for this lecture on coronary artery disease and lipids in diabetes. The problem in diabetes is different from non-diabetics. Coronary artery disease is the main cause of mortality in diabetes. If you take type 2 diabetes, around 80% of them possibly develop macrovascular disease, and also the mortality is mainly due to the macrovascular diseases. And a large number of diabetic patients do not survive their first event. In addition, they have dyslipidemia and hypertension, which increases the mortality and morbidity. Even in type 1 diabetic patients, where the survival has improved largely over the last decades, the main cause of mortality is due to cardiovascular disease in patients who are having nephropathy. In those who are having proteinuria in type 1 diabetes, the mortality is around 15 times higher due to coronary artery disease. And in overall the diabetic patients, this coronary artery disease is 3 to 4 times more common compared to non-diabetic patients. Also, in females, the loss of premenopausal protection is found in diabetics. The sudden death is more in diabetics, 50% higher in males and 100% higher in females. Also characterized by multiple lesions, multiple vessel involvement and more distal involvement. It means more difficult in managing these arteries. Also, these patients have atypical presentations and they present with LV dysfunction more commonly even at initial presentation. And in addition, the autonomic neuropathy of diabetes worsens the outcome. In addition to the coronary artery disease, these patients also have an underlying cardiomyopathy which worsens the outcome. Compared to non-diabetic patients, the revascularization procedures have less favorable outcome because restenosis is more common in these patients. The life of a graft or life of a stent is lesser in diabetics compared to non-diabetics. So, diabetes itself is considered to be a CAD equivalent. So, what is the pathogenesis of this diabetes, coronary artery disease? Basically, it is acceleration of the atherosclerosis. The main reason being the insulin resistance. Even in a pre-diabetic state where the fasting and the postprandial glucose values are just above the normal range, but not come to the diabetic range, the patients are found to have insulin resistance and coronary artery disease and increased morbidity compared to those who do not have IFG or IGT. So, insulin resistance is supposed to be one important underlying mechanism which predisposes to the environment where we get more coronary artery disease. The coexisting hyperglycemia, hypertension, obesity, dyslipidemia of diabetes, the altered hemorheology of diabetes, including increase in the pro-atherogenic factors, and in addition the oxidative stress, all as a conglomeration of metabolic syndrome accelerate this atherosclerosis. What are the clinical manifestations? They can present as classical symptoms like what we see in non-diabetic patients, a typical stable angina, unstable angina or as myocardial infarction pain. But in diabetic patients, many of them can have silent or painless ischemic symptoms. They can just present as a mere dyspnea or hypotension or just on acute onset sweating, syncope, or they can remain asymptomatic. They can otherwise present as complications of acute coronary syndrome like shock, conduction disturbances, cardiac failure or a reinfarction or mere ketoacidosis. The other atypical symptoms may be dyspeptic symptoms which patients get treated only for acidity or a pain in the arm or a toothache or history of sudden falls, particularly in the elderly it may be just a history of fall which may actually be an underlying myocardial infarction, or they may present as vomiting and giddiness where a myocardial event has to be ruled out. So, presence of other vascular involvement or presence of additional risk factors should prompt the treating physician to look for an acute coronary event in any patient who presents with atypical symptoms. So, in acute coronary event, when we are evaluating this patient, a resting ECG has a low sensitivity. A normal ECG does not rule out an acute coronary syndrome. A combination of clinical features, serial cardiac enzyme evaluation and ECGs, and also symptomatic relief of the treatment with the treatment of non-cardiac events only will tell us whether the patient had an acute coronary event or not. So, this all should be evaluated to the ultimate satisfaction of the treating physician. So, in the absence of an acute event, further cardiac testing has to be done in those patients who have typical or atypical cardiac symptoms or who have an abnormal rest line baseline ECG. In addition, it is also being proposed to be done in those asymptomatic patients who may be having an asymptomatic coronary artery disease. So, accurate and early diagnosis is likely to benefit those who are having severe disease, because revascularization definitely improves the outcome. So, what do we do in asymptomatic coronary artery disease? First, we look for evidences. One is the UK PDS study definitely has shown that asymptomatic patients with type 2 diabetes mellitus have an increased mortality rate, a 10-year mortality of around 20% more, and also the incidence of myocardial infarction being 28% in asymptomatic patients, and this includes a fatal MI of more than 9%. The other study, the diabetes intervention study, has shown that in middle-aged, newly directed diabetic patients who are just on diet control, 15% of them had myocardial infarction within 10 to 11 years. So, this explains that asymptomatic coronary artery disease has to be screened for and looked for in patients who are having additional risk factors at least. So, what are the risk factors? Presence of other atherosclerotic vascular disease, presence of albuminuria, or having an abnormal baseline ECG without any symptoms like Q wave changes or deep T wave changes, or a left bundle branch block or STT wave changes. Non-specific changes also have been recently proven to have an underlying cardiac disease. The patient presenting with unexplained dyspnea or other atypical symptoms need evaluation, or if the patient is having risk factors like uncontrolled hyperglycemia, hypertension, dyslipidemia, diabetic retinopathy and autonomic neuropathy, all are supposed to be markers for having a vascular disease in the body. In addition, the usual traditional risk factors like age more than 40 years, the male sex, physical inactivity, smoking, family history of coronary artery disease and obesity are considered to be risk factor for developing coronary artery disease. So, to identify asymptomatic in asymptomatic patients the presence of coronary artery disease, a risk factor based approach has been proposed, so that we can modify the risk factor, or through surveillance we can treat the patients promptly and also by revascularization procedures. But recently studies have questioned the risk based assessment of asymptomatic coronary disease, but when the risk factors are higher, we have to treat these patients promptly. Cardiac mortality risk increases in those patients according to the presence of the risk factors. The patient who is having a low risk, the mortality is around less than 1% per year. When the patient is having intermediate risk, it is 1 to 3%, and when they are having high risk, the mortality is more than 3%. So, a patient who is being followed up regularly in a diabetic clinic, the cardiac risk factors have to be monitored and assessed at least once in a year. So, how do we further assess in an asymptomatic patient? The one is the presence of a stress ECG, use of stress ECG. It may be helpful in excluding triple vessel disease only. It does not give information about a single vessel disease or a double vessel disease. So, stress echo is reliable, valuable and cost effective, but it is not available uniformly, and also it does not give information on the nature of the lesion. Angiography does give information on the site of the lesion and the nature of the lesion, but eccentric lesions are not visualized, and it does not give a 3D image. Nuclear medicine scan using radiopharmaceuticals definitely helps, but it is not widely available. And the latest is a CT angio and a cardiac MRI. CT imaging defines the atherosclerotic burden. It also gives information on the non-calcified atherosclerotic lesions and also on the degree of narrowing. While cardiac MRI can be used to assess the perfusion and the wall motion defects, but it is not available. So, when do we do a coronary artery calcium scoring? This is done using a CT imaging of the heart. Basically, the calcium score is a marker for the overall atherosclerotic lesion, but it is not useful when the calcium score is in the lower range. When the calcium score is more than 400, it indicates a relatively high risk. So, it is having a definite role in the high risk patients, but it does not have a role, or the role has not been assessed in the low risk or the intermediate risk groups. And also in the elderly patients who are having renal insufficiency, and even without renal insufficiency in the elderly patients, a high prevalence of coronary calcification is seen, which may not be predictive for a coronary artery disease. So, in asymptomatic subjects, screening for coronary artery disease is recommended at least for selected individuals in whom medical intervention has not, where you have not met the goals after medical intervention, or when there is a very high risk for coronary artery disease. So, what is the warranty for a normal cardiac testing? What is the warranty period that you need not do when a test has come normal in a patient who is having diabetes? It has been shown that at least within 2 years the cardiac event rate is low. So, maybe for every 2 years, after every 2 years, we may have to rescreen the patients who have been negative for the previous screening tests. Coming to the management of the coronary artery disease or the risk factors in these patients, what is the difference in diabetes is these patients have more extensive lesions, more restenosis, more atypical symptoms, and they need repeated interventions and repeated hospital admissions with repeated interventions, and also they are having a high incidence of post-intervention complications. So, a high degree of suspicion during evaluation of the asymptomatic patient and optimization of therapy with a regular follow-up are vital in these patients. So, taking the medical management, that is one trial, the COURAGE trial, which has shown that intensive aggressive medical management is as equal to a percutaneous intervention plus intensive medical treatment. The event rate in diabetic patients is supposed to be approximately 5% per year. So, what are the interventions? One is the diet, that is lifestyle modification with diet and physical activity, reduction in the stress levels and cessation of smoking. Physical activity, achieving a weight loss around 5 to 7% from the baseline is shown to have definitely an impact on the cardiac outcome. Increase physical activity by at least 150 minutes of moderate intense aerobic activity or at least 90 minutes of vigorous aerobic exercise per week has shown to be efficient, and it is being recommended. Overall, at least 5 days per week of physical activity with no more than 2 consecutive days being without a physical activity is recommended. And for long term maintenance, a larger amount of work is supposed to be done, 7 hours of moderate or vigorous physical activity per week. And regarding the exercise, it has to suit the patient. In those patients who are having a peripheral neuropathy or having a high risk food or having a peripheral vascular disease, recommending a walking exercise or a running exercise is not feasible. In those patients, an sitting upper limb exercise has to be recommended. And those patients who are having a cardiac failure, the limit of the exercise should be based on the cardiac tolerance. Also, patients need to be cautioned against barefoot walking and using ill-fitting shoes. As far as the diet is concerned, basically in overweight patients and obese patients, the calorie restriction has to be implemented so as to achieve a weight loss as near as possible to the ideal body weight, or at least a weight loss of around 5 to 7% of their baseline body weight. In addition, those who are having high risk factors for atherosclerosis, the restrictions have to be made on the fat content and also on the salt content of the diet. Among the total calories, 30% of the diet has to be given from fat, where the saturated fat should be less than 7% of the total intake, and the monounsaturated fatty acids being 10 to 15%, while the polyunsaturated fatty acids being around another 10% of the total calorie intake. Well, trans fatty acids have to be reduced drastically, while carbohydrate should form the main source of energy, forming around 50 to 60% of the total calorie intake, and proteins remaining around 10 to 15% of the total energy intake. The patient has to be advised on taking ample dietary fibers, and alcohol has to be in the moderation, particularly 2 drinks for a male and 1 drink for a female, and also the reduction in the sodium content to coming less than around 3 to 4 grams per day. Regarding blood pressure control, systolic BP of 130 to 139 millimeters and diastolic BP of 80 to 89 millimeters can be given a try with the lifestyle modifications. If they are persistently high, they need to be initiated on lifestyle plus drug therapy. And the first line therapy would be ACE inhibitor or angiotensin receptor blocker, but other class of drugs have demonstrated that CVD events can be reduced in patients with diabetes when BP target is achieved. The drugs being beta blockers, thiazide diuretics, and non-dihydropyridine calcium channel blockers. In the elderly patients, the BP should be reduced gradually, and during monitoring of these patients, either at the time of diagnosis or at frequent visits, orthostatic hypotension has to be documented. Coming to the lipids, which will be discussed in detail later, lipids should be tested at least annually and more often in those patients where the goals have not been achieved. In adults less than age 40 years with a low risk lipid profile, that is the LDL cholesterol less than 100, the HDL more than 50 and the triglycerides less than 150, the lipid assessments can be repeated once in 2 years. Well, those in more than age 40 years with additional risk factors, it has to be screened annually and more often if the goals are not achieved. And the LDL cholesterol is targeted less than 100 milligrams, those who do not have additional coronary artery disease factor, and in those who are having additional risk factors, it should be brought less than 70 milligrams. And diet and physical activity can have can help in achieving a reduction of around 25 to 30% of LDL cholesterol, but if it is not achieved, drug therapy has to be initiated. Regarding antiplatelet drug therapy, aspirin therapy in diabetic patients is recommended in those who are having increased serious risk, including those who are having age more than 40 years. It is contraindicated in those who are having bleeding tendencies or who are already on anticoagulant therapy and active hepatic disease. In those patients who are not tolerating aspirin, other antiplatelet drugs may be added. Aspirin therapy should not be recommended to those children less than for children and those who are less than age 21 years for the risk of Ray's syndrome. Regarding tobacco, all patients should be asked about tobacco use at every visit, and every tobacco user should be advised to quit, and the willingness to quit should be assessed. Assistance can be given by counseling and also developing a plan to quit. Maybe a use of a psychiatrist can help in those patients who are finding it difficult to withdraw. And during follow-up, the patients need to be assessed regularly regarding their tobacco reusage, and also they have to be referred to special programs where pharmacotherapy can be used. For example, the newer available drugs like nicotine replacement patches or bupropion. Regarding the glycemic control, optimal glycemic control has to be achieved at HbA1c less than 7% in preventing or retarding the progression of the cardiovascular diseases. There has been concern about sulfonylureas because sulfonylureas can act non-specifically in other receptors which are found in the cardiovascular system. They may hinder the ischemic preconditioning, and also drugs like glibenclamide and chlorpropamide can have a prolonged hypoglycemia, which is a stress on the heart. Newer drugs like glimepiride are found to be more specific on the beta cells and they do not have this adverse side effect. So, they may be used in those patients who are still a candidate for oral hypoglycemic agents. Metformin reduces the risk of coronary artery disease, but it should not be used in patients who are having congestive cardiac failure or renal failure. Otherwise, it can be used as a first line drug in obese patients. While thiazolidinedione improve the insulin sensitivity, they are a point of concern in those patients who are having a risk of cardiac failure. So, those who are prone for volume overload are not supposed to be started or continued on thiazolidinediones. Regarding insulin, there has been a voice of concern regarding using insulin, because in insulin resistance there is hyperinsulinemia. So, are we inducing hyperinsulinemia by giving exogenous insulin? At present, the consensus is that when insulin is indicated, the treatment has to be given with insulin. For hyperglycemia is supposed to be more atherogenic. In chronic phase of diabetes, the glycemic control has to be suited according to the complications of the diabetes. In those who are having chronic complications of diabetes and those who are having a secondary OHA failure with end organ damage, continuation of insulin is advisable and OHAs are contraindicated, absolutely or relatively. In uncomplicated diabetes, metformin or newer sulfonylureas can be initiated and titrated if the HbA1c is achievable, and maintaining a HbA1c less than 7% without significant hypoglycemia has been proven to be beneficial in patients having coronary artery disease. What do we do in acute coronary syndrome? The management in acute coronary syndrome, including the usual management of hemodynamic stability, control of hypertension, control of hypercoagulant state, control of dyslipidemia. The diabetic control, mainly the control of hyperglycemia, has to be with insulin therapy. This has been proven with the DIGAMI study. And those patients who are not responding, or those patients who are candidates for primary intervention, have to be taken promptly. During any acute illness, insulin is mandatory. So, in acute phases of a coronary artery disease, insulin has to be the drug of choice for controlling the blood sugars, and the in ICU blood sugar control has been shown to have a significant outcome on the morbidity and mortality. Insulin infusion followed by intensive subcutaneous insulin therapy has shown to change the outcome significantly. Once the patient has been stable, they can be switched over from insulin infusions to a short-acting insulins, followed by once or twice daily premixed insulin subcutaneously given. The frequent monitoring and simple logical dose adjustments are the secrets of successful management. The education given both to the patients and the family during the acute phase has shown to sustain the gains. And the patients after acute coronary syndrome have to be maintained on cardioprotective drugs, antiplatelet, beta blockers, ACE inhibitors and statins. Surgical interventions compared to percutaneous transfemoral coronary angioplasty, coronary angiobypass has been shown to have a better outcome, because these patients have multiple vessel involvement and more distal involvement. And it has been found that the artery grafting using mammary artery is more beneficial than using the saphenous vein in diabetic patients. Coming to dyslipidemia in diabetes, there are unique alteration in diabetic patients, not like what we see in the familial dyslipidemias and other dyslipidemias. Here they are characterized by hypertriglyceridemia, and the cholesterol and small dense VLDL, or cholesterol rich small dense VLDL is present, and the HDL is highly ineffective in diabetic patients. This HDL is more triglyceride rich, and also the LDL is dangerously modified. It is small dense glycated LDL which is more oxidative. So, defining the risk targets the risk cutoff values for diabetic patients as far as lipoprotein levels are concerned. Total cholesterol is considered to be high risk if it is more than 240. A value 180 to 239 is considered borderline, and a less than 180 is supposed to be low risk. As far as LDL is concerned, a value more than 130 is definitely high risk, 100 to 129 is intermediate risk, and less than 100 is low risk. But in the presence of other coronary artery risk factors, a value less than 70 is recommended. While HDL cholesterol, a value less than 35 milligrams is supposed to be a high risk, while intermediate value is 35 to 40, and a low risk value is more than 50. In the triglycerides, a value more than 400 definitely is a high risk, requires treatment. A value of 150 to 399 depends on the presence of other risk factors, is supposed to be a moderate risk. A value less than 150 is supposed to be a low risk. So, how to manage this dyslipidemia? As we have already seen, in any metabolic illness, the first thing is the management of the lifestyle. In all patients, initially at the screening visit, the patient should be looked for having dyslipidemia. If the patient has dyslipidemia, also we have to rule out the use of estrogens or use of alcohol, and also modifiable risk factors like uncontrolled diabetes, hypothyroidism, steroid intake, and also we have to look for familial dyslipidemia. Elevated LDL cholesterol is identified as a primary target of lipid lowering therapy, and with the dietary modification alone, 15 to 25 milligram fall in LDL is expected. If more than one cardiac risk factor is present, then treatment is initiated even when the LDL is more than 100 milligram. Aim is to have a reduction of around 30 to 40% from the baseline value. If no risk factor is present, LDL therapy is initiated if it is persistently more than 130 milligram, even after strict behavioral modification. What is the role of physical activity in dyslipidemia? It helps in reducing triglycerides and LDL levels and improves the HDL. This is the least cost effective HDL management is a physical activity. While diabetes control improves lipids in type 1 diabetes, but in type 2 diabetes still some lipid abnormalities persist. After control of the blood glucose, in type 1 diabetic patients, the triglyceride values revert back to normal. The glucose lowering oral drugs have main effects on triglycerides because they reduce the hyperglycemia, but they have minimal effect on the HDL level. The lifestyle modification should be monitored at regular intervals with the consideration of pharmacological therapy between 3 to 6 months after trial of lifestyle modification. Management of triglycerides, mainly they are elevated in uncontrolled diabetes, and they improve on blood glucose control. A value of less than 150 milligram is considered to be safe, and value more than that is considered to be a surrogate marker for atherogenic lipoproteins. It represents a secondary target for lipid lowering once the LDL target has been achieved. And the treatment is the drugs is initiated if the values are persistently high or if the baseline value is more than 400, because the risk of pancreatitis increases. So, choice of drugs, if it is predominantly hypertriglyceridemia, the first line of drug will be a fibric acid derivative, and the second line of drug will be HMG-CoA reductase inhibitor, that is the statins. The third choice will be nicotinic acid derivatives. While if the baseline LDL is a predominant abnormality found, then the first choice is HMG-CoA reductase inhibitor, with the second choice being fabric acid derivative, the third choice being bile acid sequestrants. But these drugs can be interchanged if the patient does not tolerate the drugs. If the patient has both increased LDL and increased triglyceride, first initiate on high dose statins and add on fabric acid derivatives. So, how do fabric acid derivatives work? They act by decreasing the VLDL production and increasing the lipoprotein lipase activity. So, they achieve a triglyceride reduction of around 25 to 50% in a given patient population, while there is a mild reduction, mild raise in the HDL levels by around 10 to 20%, while the effect on LDL is minimal. The drugs commonly used are gemfibrozil, fenofibrate and the clofibrate. And the side effects most commonly being gallstones and myopathy, but myopathy is rare in these patients, and the gallstones are usually asymptomatic. HMG-CoA reductase inhibitor, they act by decreasing the cholesterol synthesis and also increase the LDL receptor mediated clearance of the cholesterol. They increase the surface LDL receptors. They reduce the LDL levels by around 50% in some of them, but usually on an average by 30%, and the triglycerides by around 25%. And the commonly used drugs are atorvastatin, rosuvastatin, lovastatin and simvastatin. The side effects are rare, but the serious side effects being myositis, but it is present in less than 1% of the patients who are being treated on HMG-CoA reductase inhibitor. And asymptomatic liver enzyme elevation can be found in around 2% of the patients. The other agents being nicotinic acid, which predominantly decreases the VLDL production and also has a direct HDL increasing effect, and it decreases the triglyceride by around 20 to 50% and raises HDL by 15 to 35% and reduces the LDL by around 5 to 25%. The usual dose is around 1.5 to 3 grams per day. The side effects being hyperglycemia, which can still be managed by using the anti-hyperglycemic agents, skin flushing, which can be intolerable in some of the patients, and elevated liver enzymes, GI irritation and ocular toxicity. While bile acid sequestrants, they decrease the LDL by increased sterol excretion and also improving the LDL receptor number and the action. Cholestyramine and cholesterol are the usual agents, and basically they are having a GI side effects as a main side effect. The other agents, one is ezetimibe, which inhibits the cholesterol absorption and decreases the hepatic cholesterol delivery and increases the uptake. Primarily, it is an LDL lowering drug given as a 10 mg once daily. The recent onset concern is about a suspected neoplastic potential. Polycosanol is another miscellaneous agent which is given as a dose of 10 mg per day. Basically, it has been studied in older subjects having an antiplatelet action in addition to LDL lowering effect. So, how do we monitor these patients? Basically, we have to remember the targets in these patients are HDL achievement more than 40 in males and more than 50 in females, triglyceride less than 150 and LDL less than 100. It has to be brought down further in those patients who are having coronary artery disease less than 70 milligrams and achieving a total cholesterol of less than 180 milligram percentage. Therapy is monitored and muscle enzymes have to be tested in those patients who complain of symptoms suggestive of myositis. In addition, liver enzymes have to be monitored, and if the liver enzymes are elevated, the drug has to be discontinued, and particularly in those patients who are having an elevation of the liver enzymes by more than 10 times the baseline value. The doses have to be reduced and renal functions have to be monitored in those patients who are having CRF and those patients who are having combination of fibrates and statins being given. So, taking all the consideration in those patients who are having diabetes and having a high risk atherogenic profile, baseline disease have to be considered when we give a combination of drug therapies. These a few examples are given here. One is the patient is having hypertension with a stable angina, the baseline of drug will be, in addition to drug to control diabetes, antiplatelet drugs and beta blocker would be the primary drug which has to be given. When the patient is having a coronary disease with LV dysfunction, then the first line of choice in addition to blood sugar control will be AC inhibitors, diuretics and antiplatelet drugs. And when the patient is having a coronary artery disease with a coronary artery stent, then antiplatelet drug as a combination aspirin and clopidogrel along with the dyslipidemic drug would be the choice of the drugs. And when the patient is having a nephropathy, it will be AC inhibitors or ARBs along with antiplatelet drugs. So, all the patients who are having diabetes and having a risk for coronary artery disease, basically it has to be a combination of drugs which have been given to the patient, but the priority has to be different in different patients. Thank you.